Hello, and welcome to Firsthand Segregation, an intimate look at segregation in Chicago. My name is Tim Russell, Vice President of Community Engagement and Diversity, Equity, and Inclusion for WTTW and WFMT, and I'm excited to have you join us for this important conversation. WTTW's purpose is to enrich lives, engage communities, and inspire exploration. We are dedicated to extending the reach of our content into our diverse community. Through content, events, community conversations, and educational and fun activity for kids and families, building tangible connections to our audience is a mission-critical endeavor and continue to inspire us to be Chicago's window to the world. In February, we launched Firsthand Segregation, part of WTTW's award-winning multimedia, multi-platform initiative, focusing on firsthand perspectives of people facing critical issues in Chicago. Throughout 2022, WTTW's Firsthand Segregation will put a human face on the impact racial divisions have on individuals, the city, and our region through a documentary series, expert talks, text, and visual journalism. In partnership with Southside Weekly, Invisible Institute, and our own WTTW newsroom, and community discussions and engagement in partnership with Folded Map Project and the Metropolitan Planning Council. You can find this content on our website at wttw.com/firsthand. Today's conversation is in partnership with the Metropolitan Planning Council. We'll explore the inequities of health disparities that plague our communities as a result of segregation, along with highlighting solutions that aim to foster a future of health equity for all residents. This conversation will be moderated by Darlene Hightower, President and Chief Executive Officer of Metropolitan Planning Council. Darlene is a tireless advocate for health equity. She has led the development of Westside United, a cross-sector collaborative aimed at improving health and economic vitality on Chicago's West Side. Her leadership in health equity throughout the COVID-19 pandemic was nationally recognized, as Darlene was honored in 2020 with the U.S. News and World Report Healthcare Hero. And she is a Community Trust Leadership Fellow, as well as the University of Chicago Civic Leadership Academy Fellow. Before we get things going, I'd like to extend a very special thanks to the supporters of this project, who you can see listed here. Without the generous support of these donors, sponsors, and WTTW members, Firsthand would not have been possible. Now, let's watch the trailer for Firsthand Segregation, followed by Darlene Hightower, President and CEO of Metropolitan Planning Council.
As you look at the city, you can almost tell by the skyline, right, where the opportunity is.
Segregation is deliberate when it's economically and racially driven.
We're pushed out of certain neighborhoods.
They pretty much let you know that they really don't want you here.
It was very Mexican, but no black people.
How do we figure this out? How do we become more participatory?
Every neighborhood should reflect what our city is about. And it's about everybody, not just one race.
Hello, everyone. My name is Darlene Hightower. I am the President and CEO of the Metropolitan Planning Council. I'm so excited to be here with everyone today. I know we're going to have a really fantastic conversation. But before we do that, I want to introduce our amazing panelists for today's discussion. First, we have Dr. David Ansell, who is the Senior Vice President and Associate Provost for Community Health Equity at Rush University Medical Center, and he is also the author of The Death Gap. Dr. Ansell did his medical training at Cook County Hospital in Chicago, and he spent 13 years at County as an attending physician. He was also chairman of internal medicine at Mount Sinai, Chicago. In 2011, he published a memoir of his time at Cook County Hospital called County: Life, Death, and Politics at Chicago's Public Hospital. His latest book is called The Death Gap: How Inequality Kills, and that was published in 2017. Welcome, Dr. Ansell. And then I also have the fantastic Debra Wesley, who is the founding CEO and president of Sinai Community Institute, which is in North Lawndale. It was established in 1993. Ms. Wesley is the Executive Vice President for Community Outreach on behalf of Sinai Health Systems, And the Institute is a health system-based human and health services organization that has touched over 565,000 people through its 70 programs since its creation. She's also a social entrepreneur, a leader, and a community builder. So welcome to you, Ms. Wesley. And before we jump into questions, to help us frame the conversation even more, we are going to have a video clip from Dr. Monica Peak, who is the associate professor at the University of Chicago, where she provides clinical care and she teaches and she does health services research with a focus on health disparities. You can watch her entire talk at WTTW.com/firsthand, but let's hear a little bit of a clip of what Dr. Peak has to say.
I'm a primary care physician at the University of Chicago on the city's south side. I'd like to tell you about one of my patients. Let's call him Mr. Jones for the sake of anonymity. Mr. Jones was a classic Chicagoan, born and raised on the south side. He loved jazz, just a great person. He also had a number of medical problems that we were working to manage: diabetes, high blood pressure, heart disease. In the beginning of 2020, right at the beginning of the pandemic, he started having symptoms of a cold. And within 48 hours, he was too sick to drive himself to the University of Chicago. So he called 911, and the ambulance took him to the closest hospital to his home, which turned out to be a small community hospital that was overwhelmed and frankly unprepared to deal with the huge influx of patients that were coming in with this new illness. I was unable to get him transferred to the University of Chicago, and he was ultimately diagnosed with COVID, and 2 weeks later, he passed away. I have many patients that are like Mr. Jones, wonderful people, working class African Americans who have chronic medical problems, the kind of problems that if you get COVID-19 put you at increased risk for worse outcomes, like death. And while I'll never know for sure if Mr. Jones would have survived had he been transferred to the University of Chicago, what I do know is that hospitals in predominantly Black neighborhoods are more likely to be small community hospitals that are understaffed and under-resourced compared to hospitals in white neighborhoods. See, that is what residential segregation does. It separates communities by race and then differentially allocates not only public funds, but other goods, resources, and opportunities to those neighborhoods. But healthcare isn't the only thing that predicts poor health in residentially segregated neighborhoods. Black neighborhoods are less likely to have all of the things that are associated with good mental and physical health compared to white neighborhoods. Clean air that is unpolluted with environmental toxins, clean water that does not have lead, green spaces and parks, quiet places for meditation, safe and stable housing, strong educational systems, opportunities for employment, pharmacies and grocery stores and other things that we build in the environment that people need to promote their health. All the things that we need to have a vibrant, strong community. The absence of those things causes physiological changes in our bodies. The presence of chronic discrimination and racism also causes physiological changes in our bodies. Those two things together are more likely to predict poor health than merely the absence of a health clinic or a hospital.
So that clip was really riveting, and I'm hanging on Dr. Peak's every word, and I feel myself being a part of the Amen choir, as she's talking about some of the challenges that are faced in the African American community when it comes to health disparities and when it comes to segregation. So I want to frame a little bit of data on those two issues and then dive into our questions with our two panelists. So the Chicago Department of Public Health issued the State of Health for Blacks in Chicago about a year or so ago. And in that report, it talks about disparities in chronic disease, among other things. There's a statistic there that diabetes-related death rates among African Americans is 70% higher than whites. Black infants are almost 3 times as likely to die in their first year of life compared to whites. Blacks accounted for half of the people living with HIV. And then we know that there are life expectancy gaps as high as 16 years or more between neighborhoods that are predominantly white and those that are predominantly African American. And these kind of statistics lead us to conclude that your zip code really can determine the overall health and well-being of the individuals that live there. And then switching to a report that the Metropolitan Planning Council did on the cost of segregation. We've talked a lot about Chicago being one of the most segregated cities in the country, but this report quantified that and noted that Chicago has the 5th highest combined racial and economic segregation in the country, and the 10th highest African American and white segregation in the country. And the result of this not only impacts African American communities, it impacts us all because we end up with lost lives, lost income, and lost potential to the tune of $4.4 billion in income every year, $8 billion in gross domestic product, a loss of 83,000 bachelor's degrees, and our homicide rate would drop by 30%, but for the racial and economic segregation we experience here in Chicago. And so with that, I want to bring in our panelists, and I'll start with you, Dr. Ansell. What's your initial reaction to this health disparities data and to the cost of segregation data?
Well, thank you, and thank you for having me today. Well, my first reaction is that none of this is new. This is longstanding. It's been well known for years and years. We shouldn't be surprised by this because, as I said, it's been well known. In fact, the first study on that looked at differential mortality for Black people in the United States, the first organized study, was done in the late 1800s by W.E.D. Du Bois, in a book that he called The Philadelphia Negro, in which he laid out how racism caused mortality. So this is not new data. The story that Dr. Peak told, I'm well aware of. And now you have this co-prevalence of where people live in segregated neighborhoods, and then the services that are available into those neighborhoods are often substandard for the conditions that they have. That's less visible to people. I remember Dr. Peak speaking to me about this case, and that she even as a leading physician at the University of Chicago could not even get her own patient rescued from that institution. So the human tragedy of this is unacceptable. It's palpable. It's unacceptable. It's unjust. And then I want to leave on this note. We're always talking about segregation as if it's a Black community phenomenon, when in fact affirmative action and segregation are white community phenomenon. White people in this country have always had a form of affirmative action. Doesn't mean everybody's thriving, but we always think about the segregation when in fact it was the segregation of white communities that led to the segregation of Black communities. And I think we've got to understand this concentrated affluence in this country and the concentration of capital in some neighborhoods compared to another, long-standing trends have left whole swaths, not just of the city, but of the country, bereft of capital.
And so I'm going to stop you right there, because once you get going, you get going. And I want to make sure that I bring in Debra Wesley. And because we're family on this call, I'm going to call everybody by their first names going forward. So David and Debra. And Debra, I'd love to get your insights on this too, health disparities, as well as the segregation data that I discussed earlier.
Well, I concur with David. And first of all, thank you for inviting me. I really appreciate this conversation, and it's an important conversation. I concur with David's analysis. This is not new. This is not new. I was born and raised in Chicago, and Chicago was very segregated. And yes, I just really quick, when we moved, the house I live in right now, we were the first Blacks on the block. There are no white folks here at all. And the assets of the community has changed significantly. And it's very disturbing. And over time, what I see happening is we have normalized something that shouldn't be normal. Our communities across the city and anywhere should be a level playing field, a playing field where our residents can thrive, can get what they need right in their own community. That's the result of, and we see the end result of that by the health inequities that are occurring. The other thing I want to say is, as an African American, we had no voice. People wouldn't listen to us when we're having pain, when there are issues that we know something is not right, but we weren't believed. I guess because we're Black, we're supposed to be stronger and take pain in a different way. We know how to make something out of nothing. So just because you're hungry, I know you can go find something, concoct something up. So I think that the data, it just documents that this has been going on for a long time. The question is what are we going to do about it? And what's happening now to really address something that's been longstanding, and segregation in itself has to change.
Yeah, I really appreciate that last point of, what are we going to do about it? Because as you both are saying, the data is not new. I think the challenge is the apathy in doing something to address the data. I also appreciated what you said, and I wrote it down. We've normalized these disparities. We've normalized the data and as if it's normal, as if, there aren't underlying systemic reasons behind some of the data that we talked about before. And then the last point that you raised about how African Americans are viewed within healthcare and kind of the bias that comes in with that. I don't think that is has gone away either. Like, there are recent studies that talk about differences in treatment that African Americans receive. But I want to ask, there's a sense that the challenges that we're talking about are limited to the African American community, and that it doesn't impact other groups. So how do we address like a sense of apathy? Like, that's happening to those people. It's not happening to me and my family, so why should I care about it? And David, I'll come to you. But before you start, I want to remind everybody, we do want this to be a conversation. If you have questions, please put them in the chat. We know 90 of you all are watching, and we know you have thoughts, so please put your questions in the chat. But David, what do you think about that? How do we address the sense of apathy?
Well, it's hard to overcome apathy in that sense, but we're all at risk when those who've been most systemically excluded among us are at risk. Obviously, the easiest discussion is talk about COVID and how COVID, unfortunately got spread through, frontline workers, bus drivers and other folks, healthcare workers, who then spread it into the community. And for an infectious disease, some of us are more vulnerable than others, but we're all vulnerable. And then solutions that tend to benefit those who've been historically marginalized benefit all of us. We've seen this before. For example, when seatbelts were put in to protect children from accidents, they protected all of us from car accidents. So interventions that make a difference in one community will make a difference. The violence in Chicago, for example, or the burden of chronic disease in Chicago affects all of us. None of us are immune from these impacts. What I would like to say is we know that a child who grows up in concentrated poverty, so this is not just about Black people, it's about anybody who grows up in a neighborhood where there's a concentration of poverty, whether you're white, black, brown, or otherwise, will fare poorly, more poorly than if you if you live in a neighborhood where there's less poverty concentration. Your life chances just increase when you live in a more socially integrated and therefore racially integrated neighborhood. So, you know, the benefits accrue to all of us, though oftentimes people don't see that.
Debra, your thoughts, and then I want to come back to this poverty versus race issue. But Debra, your thoughts on that? What can we do to address the sense of apathy that this is happening to those people?
At the root, in the community, there isn't a sense of apathy. Just my take on it. There's been a cry for help for years. The issue is policymakers who are making policies not including the community in the process of those policies, not putting resources that are going to be valued by the community and take it and take the community in consideration in terms of how do we solve this problem. Resources that when you say we need to, just example with COVID, when folks need to stay in their homes, not considering multiple families that live in those homes. That's just exacerbating the problem. But resources that are put out there that don't really understand lived experiences of individuals across who are challenged by poverty, who are challenged by discrimination, by racism, all of those things. So I think that the apathy is about our voice in the community.
I also think we have to be able to show that we can make a change. I think there are ideas out there. There's great assets in these neighborhoods, and there's great examples of how improvements can be done. You know, we can spend a lot of time talking about the problem, the root cause of it. People tend to get discouraged that these are intractable when they're really not. There's an opportunity for all of us to make improvements and actually show improvements in health outcomes, but also in social outcomes as well. These are not intractable.
Yeah, I really appreciate that, David, because, you know, as I was preparing for this and just looking at the data, if you look at the data alone, it can be very discouraging. And if you talk about, you know, how long disparities have existed, it can be discouraging. But you're right, like people are working on these issues. People have had success in making things better for people. And we're going to get into that in a minute, because I don't want people to have this like Debbie Downer feeling. Like there's some really great work that's happening in the city of Chicago. But since I have these veteran healthcare folks like in front of me right now, I want to talk to you about what changes have you all seen over your decades worth of work when it comes to health disparities? Are people talking about it in a different way? Do you have different stakeholders? Like what's changed? Give us some anecdotes from your time.
Well, I'll just speak. What I see is a very intentional organizing at the very community level, coalitions that are formed that are, and I work with a number of communities that have developed quality of life plans that look 50 years from now. What's that picture we want to paint, not only for ourselves, but for our future. And those are kind of the roadmaps that are being created at the very community level. So the question is how do we support those visions and those roadmaps that have been created at the community level? So I think that there's a lot of great, amazing work that's being done at a very hyper local level.
Thank you for that. David, your thoughts?
Well, I would just echo what Debra said, and just to pull out this connection between local level activism and public policy. And I think there's been a lot of things that are happening. So you go back to the Americans with Disabilities Act, which for now, like buildings and access, curb cuts, things we take for granted, automatic doors on bathrooms, that occurred because activists in the community demanded equal treatment. That led to the Americans with Disabilities Act. We don't have that same kind of act for health disparities, but that kind of community organizing approach from the grassroots to the grass tops is incredibly important. Two, the second thing was COVID really pointed out to us that our common wealth and our common health is at stake here. And I'm going back to COVID because the United States as a country with the most expensive, the most well-funded health system in the world did among the worst of all the countries in the world from COVID because the health system was not designed in a way to be able to respond in an effective way to the needs in the community, nor is it designed to take care of those who are in the moment most medically or socially vulnerable from their conditions or social conditions. It's just as Dr. Peake said, is a great example of how a patient ends up in one place, the resources another place, and we failed miserably, and that led to a lot of attention now about the problem of racial health inequities among the things we have to address the most. For every condition for which healthcare could make a difference in every state in the United States, Black people or Native American or Alaskan natives have the worst outcomes. For conditions for which healthcare would be better, COVID highlighted that. Worst among the worst in the world. We weren't even average. Had we been average, we might have saved 500,000 lives in this country. So we just lived through this moment.
Well, you know, some like to blame the victim and say, like, what is it that people of color are doing that one is causing them to be vulnerable or two to be susceptible to things like COVID? Can we talk a little bit about that? Like, is this really about people's choices?
Absolutely not. You see folks in communities that have been long since abandoned, fighting to get a grocery store. Mm-hmm. Think about that for a grocery store. In the community I live in, which I'm not going to name, folks shop at the gas station because there isn't a grocery store. And what will they have that really supports great health? Not much. Not much, mostly processed food. There's activism around housing, really looking at, because if you look at social determinants of health, there are these root cause issues that contribute to the dis-ease in our community have to be addressed. And so there's kind of an uprising, if you will, that I see going on across the city to address this issue, that we need to have housing that's safe, housing that's healthy. You know, think about asthma in our community and how a lot of our old stock contribute to it. Getting the lead paint out of the houses, the water with the lead in it, all those things have to be addressed. But these are very activist activity that I see going on, as well as just think about it, the empty lots, turning those into productive lots, meaning where you can grow fruits and vegetables and things like that. It's amazing things that's going on.
Yeah, the word that pops in my head as you're talking, Deborah, is systemic. Like, it's about systemic challenges. David, you look like you're chomping at the bit to jump in. So come on, what are your—
Just to frame it, Deborah's white. I mean, these are not, listen, there are clearly individual reasons why some people do better than others, but most of it, if you look at the breakdown of health, only about 30% of poor health is due to belief, behaviors, biology, and the rest of it is due to social conditions and structural conditions. So I think that's one has to always be understood in every disease entity almost. One has to be looking at these social and structural forces. Give you an example. So I tell someone to go get a COVID vaccine on the west side of Chicago and say, go to CVS. If you look at the map of the west side of Chicago, there's not one CVS on the Black west side of Chicago. So something that might be easy for somebody in another neighborhood, Deb talked about food access. You say, just eat healthy, right? Something that's easy for me in Oak Park to do, but something that's not so easy to do. So we have to focus on these social and structural causes. The second thing is we have to name them. For example, if you want to eradicate malaria, in Africa or Southeast Asia, you have to go after the vector. And that vector is a mosquito. So we do a lot of stuff to control the vector. But what if the vector is structural racism and economic deprivation? You don't hear us neither naming the vector or trying to systematically address those vectors. So I think long-term, our solutions have to be going at those root cause social and structural causes. And they are political, and they're political determinants of health, because it turns out that in the United States, or even across the world, in the United States per se, based on income, where you live makes a difference with how long you live, independent of your race, based on public policy. So it's, you can live longer being poor in, say, New York and San Francisco than you can, say, in Birmingham or Detroit. So there's a public policy makes a big difference. So we have to do all of those things. Understand that social and structural determinants are the root cause of many of these ills, that we have to name them. And then public policy makes a big difference over the long term and how well people live and how long they live.
Yeah, I think that last part is really important. I mean, there's data that shows that the less segregated a city is, the better off people are from health outcomes to economic outcomes. That's a real thing. I mean, it's part of the work that we did at NPC. I also, as you were talking, I wrote down, it's like we are living different lives, and the way that you're living your life and your perspective impacts your health. So if I'm living in Oak Park with resources, grocery stores, beautiful parks to walk in, my life experience is different. My health outcomes are different versus communities like Debra mentioned, where I don't have those things. And I think I cut you off, Debra, because I think you were about to say something as well.
Well, when David was talking about public policies, I think about that even within the public sector, they're so siloed. And one hand doesn't know what the other's doing. And so what I do see happening is that erasing of the silos and trying to figure out how even within the public sector they can work together. So whether it's the Department of Health or whether it's Illinois Department of Health or Chicago Department of Health, you know, they come up with good intent to address an issue, but they need to be at the table at the same time. So it's a cohesive plan and it doesn't confuse, so that if we're going to do vaccinations, for example, we don't need to go to the same house because one hasn't had a conversation with the other. They're trying to smash the mosquito, but they're smashing the same one. So I think that the issue, a part of it is understanding that the infrastructure in terms of that bureaucracy has to change, continue to be a little bit more open and reduce, minimizing the silos so that we can get at the root cause of these issues.
Yeah, I appreciate that. I want to remind people that please put your questions in the chat. There are almost now 100 people that are on this webinar. We would love to hear from you. Any questions that you have, we would love to hear from you and, you know, get into the conversation from your perspective. I want to circle back though to something that you both have talked about. Like, I'm sure that there are people in the healthcare system that are watching this webinar now, but then there are some that are not, that may just be interested in the issue overall. But can you talk a little bit about like what social factors or what social determinants of health means? What is that and how is it relevant to health outcomes? I'll start with you, Debra, and then David, you next.
Well, one of the things that I've said, you know, being at Sinai, at least I've encouraged, particularly those who are not familiar with the communities that we serve, is don't put your car on automatic. Just come from one place, the beginning to the end. Really pay attention to the environment in which our patients come from, their lived experiences with that. And I always think of, you know, and I've been in the space of trying to, you know, work with all age groups, but in particular, a soft spot for me are adolescent parents. And yes, we want to make sure that they have a healthy birth, but we need to be asking the question, are these parents, what do we need to do to support these parents to have a healthy birth in their home, in their community, making sure that the baby is born in a healthy way, but also after the baby is out, is in the world, that they have a safe landing. That adolescent parent, what are we doing with them, and what are some of the challenges? We need to just not admit them and discharge them. We need to admit them and work with them along the way and be a partner in health, if you will, and wellness for not only the baby, but the mom and the father, all of those things. So to me, and that unpeels that. I always remember when I first started at Sinai that I started working with family planning, and I saw where there were these teenage moms who we were diagnosed in family planning, but there was no connectivity in terms of how do we assure that they get the help? How do we make sure that we are very present in their lives? So I was able to get a case manager to work along with 100, and this is time when infant mortality was off the chain in our community. I was able to get a case manager, and we tracked 150 young ladies that delivered babies, that my staff was in the labor and delivery room because they didn't have the support. We held their hands, but we had a zero low birth rate, zero. And that told me that there were issues that we were dealing with. We were making it up close and personal, not just about the physical, but the emotional, the social, and connecting with the spiritual.
And so I think there's two sides of it, right? Because as I'm listening to you talk, it's like, what are the social supports like on the back end that we can make sure that there's connection between people's healthcare and, how they're living their lives, so that they have the support and resources that they need. And in your example with birthing moms. And then there's also the discussion about things that are outside of healthcare that are upstream, like quality jobs and quality education, and how those things impact people's health outcomes. So David, can you talk a little bit about when we're thinking about solutions, like what role does focusing on the social determinants of health play? And then I'm going to come to some of the questions in the chat because people are starting to engage with us, but go with that one.
Well, just, first, if you have to decide what the vector is, right? If the vector is just doctors treating diseases when people come into the office, that's certainly, as we said, important, but a small part of the problem. But if it is social conditions, and it's actually, if you get right down to it, it's the access to power, resources, and money, or the lack of access to power, resources, and money that lead to the inequities in daily life that lead to health differences. And so we've always got to be thinking about who's got the power, who's got the money, and who's got the resources to frame it, and then organize yourself towards those things. And that's what we did at Rush, and that's what Sinai does, to say we need to organize part of our efforts towards addressing these underlying conditions in the community that deprive people of power, access, and money, particularly in Black and Brown communities, and then come up with solutions to those problems. It was a big departure for us when we took that on, but it made a difference. And I can give a couple of examples during COVID where this really made a difference in Chicago, that the focus on community resources and the access to money in things made a difference in our neighborhoods. Maybe we didn't do as well as we could have done, but we did better than we would have. And that's the work of the Racial Equity Rapid Response Team, which brought this idea of a community response to COVID a little bit late. It waited till April, but when we got into it, we made a difference. And we made a difference in a palpable way. While Chicago is third in population, it was seventh in COVID mortality of the big cities in the country. And we know that our community response addressing these social conditions helped mitigate. And it wasn't perfect, but it did help mitigate.
It wasn't perfect, but it was an example of what we can achieve when you have city government, community-based organizations, hospitals, and federally qualified clinics coming together to work on a problem. I mean, that was pretty historic, and people can push back at that a bit, but being in that space, in that moment, and seeing what folks were able to achieve is pretty tremendous. I want to turn to some of the questions that are in the chat. What's something a layperson can do to help implement the systemic change we've been talking about, besides voting for better lawmakers? So, Deborah, what are your thoughts on that? What can people do?
I think you have to make it personal. You know, when I make decisions, it's like, you have to make it personal. So if you take a look in your own community. If you're living on a block, there's a lot of garbage there, which, contributes to the environment. Maybe take that on and say, I'm going to take this on to address the garbage that's in our community. If it's a house that is abandoned, that needs to have some kind of some intervention, to say, but I think you need to make it personal, because then your passion will show, but also the results will be amazing.
What about you, David? Your thoughts? What can people do to address these challenges?
Well, one is be interested in these problems. And I think, Deborah talked about what you can do on your own street, in your own neighborhood. Certainly there are a lot of organizations in the city, but our money's segregated. Our social lives are segregated. So I live in Oak Park, and until many years, it was more likely that I would go downtown into the West Loop from Oak Park than Garfield Park. Imagine if we showed up at the Black Culture Week in Garfield Park this summer and dropped some money in Garfield Park on those businesses. Because our money is segregated. There's many things about our lives. If you think about our own personal lives, when do we go to a neighborhood, if you're white, a neighborhood of color? And even if you're a Black person, when you've gone to a Latinx neighborhood or vice versa. So part of this is showing up with our money in neighborhoods and supporting businesses as well. But I do think there are a lot of organizations around this city, in the region, that are doing this work. So you can never not do this work alone. You have to do this collectively. And there are plenty of great organizations that are doing this work that you can volunteer for, all around the city.
Thank you for that, David. So we have another question in the chat about, can we name explicit strategies that we think can help dismantle some of the aspects of Chicago machine politics that contribute to segregation and perpetuating racism? That's one. And then other questions in the chat about more policy and the connections between predatory lending practices and housing policies. I'm going to jump in on that one, because there are a number of things that come to mind for that. And one is a study that came out through WBEZ a couple of years ago, looking at lending practices with certain banks. And it basically showed that 68.1% of lending that was happening within the Chicagoland area went within white neighborhoods. And so banks are playing a role in this, and that segregation is perpetuated based on how we're investing in housing in certain neighborhoods and not in others. That's one. And then just thinking in general about community economic development and where resources are going. We are doing research now with respect to that, to see if communities that need it the most are being able to access some of the federal and other funds to make their communities better. And the data is showing that they are not accessing funds that are supposed to be for under-resourced neighborhoods. And so I think it's about looking at those policies that perpetuate segregation and also perpetuate disinvestment in communities of color. And I'll get off my soapbox and move on to other questions that are in the chat.
Well, can I add that I think, although you say the power of your vote is so important. And even, we focus on the governor and the president and everything, but you're older people. We need to make sure that the folks who are representing us at the very local level truly represent the values of the community, your values. So, and ask those hard questions before you vote for them, as opposed to after, in trying to keep people accountable. So I think voting is going to be critical, as you know, across this country, particularly for communities of color. Our vote is being challenged, and we do not want to see that happen in our city.
Yeah, I love that you raised that. It reminds me of a conversation that I had with Richard Townsend, who runs the Lawndale Christian Economic Development Corporation. We were talking about voting. He's like, it's so important, but that's only like a piece of democracy. Like, we've got to be talking to our, leadership, our aldermen, like you just said, Deborah, well before it's time to cast a ballot. Like, what are our interests? What do we want to see happen in our neighborhoods, and holding people accountable for that? It's about ongoing community engagement. We have another, oh, go ahead, David. And then
I just see this, just on this point, I see a connection between the racial health inequities, not even disparities. Disparities are different, inequities are unjust. Economic inequities, people working but not able to live well, and the democracy. And it's democracy in daily life that's most important. Let me give you just a recent example. In Garfield Park, a collaborative was created, lowest life expectancy, poorest health outcomes on the west side of Chicago. And there are a lot of bad health outcomes. But to improve the community, there needed to be a table set, and it's a wellness collaborative. And then a grocery store closed in that neighborhood under the cover of night. Friday night it was open, and by Saturday morning the signs were off and they left, and they literally skulked out of the community. Now, had that happened a few years ago at Rush, we would have never known about it, but the community knew about it. People organized and held demonstrations, got the aldermen engaged and the mayor engaged, and now the city council is going to purchase the store, and then hopefully the community will buy it and try to get a grocer in that store. But that's democracy in action. It's the street democracy. It's the democracy that occurs when you raise your voice. And that's the way that health, economics, and community development can all go together. There's not enough of that day-to-day kind of democracy.
Yeah.
Yes, voting is important, but this day-to-day work of community building around wealth and health is critically important ingredients, and people can get involved with that.
Yeah, I agree with that. Like, there are both sides to the coin, like one organizing on the front end so that you constantly have a relationship with leaders and they know what your concerns and needs are, and then voting on the back end to make sure that they're doing what you wanted them to do and are addressing your concerns. We have another question. How can we develop or communicate? You're gonna love this one, David. The ROI that will cause those in affluent communities to support the necessary policy changes that will decrease disparities. So it's like, how do we show people that it's in their best interest to deal with these issues? That's the question. It's the ROI one. And I know you have a response for that one, David.
Well, I generally, on these questions, first of all, we live in a country in which everything we talk about the material ROI, but not the social return on investing. So I start usually by saying is no one asked us to create an ROI when through policy and laws and procedures and practice, we segregated neighborhoods by law and then extracted capital out of it. It's had a huge human cost for which no one's been ever held accountable for. And then, I'm always under the belief that our biggest challenge is not convincing people who maybe live in concentrated affluence in, what's in it for me type of situation versus convincing those who are allies and friends. To paraphrase Martin Luther King, it's really the indifference of our friends that's our biggest risk here, because together we can change policy and procedure. It turns out in this country that most white people, as evidence showed, do not want to live in neighborhoods with people of color. And it's
that's not shocking to me.
And well, I just want to say, and that's why we have to look at the problem of affirmative action for white people in concentrated affluence has created the conditions, has partially created the conditions under which people now suffer. So I don't think the goal is to convince people who may not change that this is the right approach, but convince those of us who are aligned to drive for the kind of public policies that'll make a difference and take the actions in our current companies and corporations and not-for-profit organizations to contribute to the positive change that is going on in neighborhoods right now. We just have to double down on it.
Yeah, but if, for the person that asked this question, if you wanted to influence folks and provide a resource to show how segregation impacts them, take a look at Metropolitan Planning Council's Cost of Segregation report, which boils down the economic backlash that we suffer as a region because of racial and economic segregation in our neighborhoods and community. And then Deborah, we all have another question in the chat, and I love this and so appreciate that someone raised it. And it is, what can young people do? You know, what can they do to be a part of the systemic change and be a part of addressing health disparities and segregation and all the things that we've been talking about today?
Well, I know that we are begging across our communities in Chicago to engage youth, to take the time to walk along with us, because we're going to be handing off the work to you. So what better way in terms of having a voice and having a part of it? I know that there are a lot of nonprofit organizations as well as for-profit that would love to have youth at the table. And I mean, there's just so many ways that you can do it. Even if, you know, I'm not a social media person, but God, are you guys the people, and help us get the messaging out? What better way when we were trying to get the message out around vaccinations, but to partner with our youth to get the message out? And because, so I think there are a lot of different ways. It's just that raise your hand and we're gonna grab you. And if you can put your name in the chat, I'll make sure we grab you.
I'll send it to you. But I also want to keep this conversation going about solutions and what we're doing to address health disparities. Like, you all are doing some incredible work. And Deborah, I'll start with you. You oversee the Sinai Community Institute. Can you talk about the reason why you founded the Institute and give some examples of work that you're doing to address health disparities?
Well, I say, let me just say this, that, you know, I've been at Sinai for 35 years, but I'm a product of North Lawndale, grew there. And I'm a social worker, that's my background. And so I've always been someone to look outside of the medical campus, if you will. And so I wanted to be at an institution that cared about the community as much as they cared about providing the medical services. So for me, Sinai's been a great home for me to live in, if you will, during the daytime. It was important to me, and like I said, remember I said, it's gotta be personal. I just can't see when a 11 or 12-year-old comes in pregnant to just deliver a baby and say, off to do what you do, kind of thing. I felt it was our responsibility to be able to really dig deep and get personal and find out about their world and see how we collectively can help them thrive. That being said, back then there was no term called social determinants of health. I just said that there were cuts that we saw and there were cuts that we didn't see. And because we were under I was just a part of Mount Sinai Hospital at the time, when I wanted to do programs in the schools, when I wanted to go out and partner with daycare centers and educate around sickle cell or whatever you name it, they said that wasn't the job of a hospital. You just need to go and treat the cut. And so what we did, by the grace of God and the wisdom of the board and the leadership, we were able to spin off and create Sinai Community Institute, which will be 29 years come June. And it's really about a community-facing organization that uses the voice of the community to develop its strategy. So it's not like Debra comes up with the answers. No, we come up with the answers, and we as collectively, the community, along with the health system, come up with the solutions, whether it's to address food insecurity through our WIC program, whether it's to address the workforce with our youth, whether it's to address our seniors who who are facing challenges around abuse, self-neglect, you name it. It's about the voice of the community. So having SCI, which is Sinai Community Institute, has given us a home base to create a kind of a plethora of services that are kind of one-stop shopping. And I just have to add, it was never created to do it alone. It was created to be able to partner with communities so that there are issues that we do, that we address, and that's our sweet spot. But there are other issues that are not. Housing, working with Richard Townsend, the employment network. Those are things that we have to address, but I wanted to have the Institute be kind of that umbrella organization to address it on behalf of the health system.
You know, what I appreciate about, you know, everything that you said is this idea of being a founder of that, like, you know, having an idea, bringing it to fruition, having it be around for almost 30 years. Like, y'all are doing it, like not just talking about it, but actually putting things in place that can address some of the things that we're talking about, whether you're, you know, founding things or writing books, which we're going to talk about in a second with you, David. It's so important that people roll up their sleeves and get engaged in this. And so I am going to turn.
Can I say that I had a voice and my voice was heard? And that's important, that I felt it was okay. It was a safe space, and it's been a safe space for me to speak my truth on behalf of the community. So that's how we do that.
I appreciate that. And so, David, you've written the book, The Death Gap, which discusses health disparities. So can you talk a little bit about the work that you're doing to address some of the things that you called out in the book, which basically you say the death gap is caused by racism. But let's talk about some of the work that you're doing to address that.
I think it's important to name root cause, because you can never actually fix problems if you don't accurately name it. But it's, you know, in naming racism and economic deprivation as root cause is important, because then you can get to how those systems are being perpetuated, maybe unconsciously or unseen in current work. But just to say, one should be optimistic about our ability to solve these problems. If things are biological, you know, you have to change the person. But if they're actually built into the system and are human created, then the opportunities to succeed are much greater. I just want to name kind of a few success stories, and Darlene, you've been involved with some of these, and Debra as well. You know, so we took on, when I was at Mount Sinai, it was very obviously when you were in Lawndale that there was something going on that was seriously wrong at the level of the community, not wrong with the community, but the conditions in the community that were making people sick, that I didn't quite appreciate when I was at Cook County Hospital. And we took on the problem of the mortality gap between Black and white women in breast cancer. And to make a long story short, this arose out of our work at Sinai. And then we made a citywide coalition to actually try to end this racial disparity. Now, I can tell you that we reduced this racial disparity over time by 50%. At the time when we first raised it, our academic colleagues were saying it's biological. The problems with breast cancer mortality, what was bad breast cancer in Black women. We got people to reframe that idea into that it was structural, it was poor quality. Back to Dr. Peek's story, there was poor quality at hospitals that served Black women in these neighborhoods. We worked to improve the quality, and we reduced that mortality gap by 50%. And it's not been done in any other city. By the way, we didn't end racism. We just improved quality. But that gave us the confidence that we could do things like that. And then, as Darlene and Debra know, we created Westside United, a collaborative between Westside health institutions and the community, the voice of the community, guiding as a guiding voice here, to address the social and structural determinants of health by hiring locally, creating career paths, investing locally, and other things. That's in its early years, but everyone thinks it's the right response. And I go back then to taking that Westside United model, which has community voice with the city's voice, with health provider voices together to solve the problem. And what we did during COVID made a big difference, and particularly our work in people experiencing homelessness. We were able to tamp down that the epidemic in that group saved lives, not just in that population, but for the rest of the city. So there's a lot of success stories, but they all have this idea of partnership and leading with the voice of the community. Doing it in silos doesn't work. Doing it together gives you the potential. And we have a little bit of a roadmap of how to do it, where we've had historical successes. And there's others as well.
Yeah, that ties into another question that's in the chat. And that's that people with lived experience are extremely valuable individuals. They have the ability to connect with people from the communities that might be hesitant to trust healthcare professionals. What are some ways that we can engage these individuals within our hospital? So how do you get that community voice inside the hospital so that your programs are reflective of what people need? Thoughts on that?
Hire them.
Listen. So the thing about this is, and one can get stuck in your own silo and have your own worldview. If you're going to do equity framing, and we're doing this at our institution, I see Shannon Andrews from the Cook County Health and Hospital System is on the chat as well. You've got to have the voice of the community at the table when you're actually beginning to think about the decisions, not when the decision's about to be made, when you're thinking through. I want to give you an example from COVID. So you remember in COVID, we had a shortage of tests, and we had this racial equity rapid response team with the provider group, and I was co-chairing the provider group. We're trying to come up with a group of rules to say who should get a test when we put a testing site in North Lawndale or in Little Village. And we said medically, only those with symptoms should get a test. And the community voice at the table said, are you kidding me? Anyone who shows up should get a test. Of course, they were right and we were wrong. And so the voice of the community can allow you to make better decisions, but they must be included up front, and they must be included at any for all policy decisions. Not all organizations are willing to do that.
Yeah, and that last part is really important too, because the voice of the community, some people only want to hear the whispers. They don't want to hear the shout. They don't want to hear like the in your face, we're going to tell you what we really think part of people's response. I think too, it makes me think about power and who's the expert, like who do we believe when it comes to solutions to health disparities? I think we've got to listen, like you just said, and recognize that there is value coming from the community. People have PhDs and lived experience. They can be just as helpful. And so when you partner that with doctors and others, I think you get the best potential response. Debra, you look like you want to weigh in on this too before I jump into another question.
No, I would just, our voices are valued, needs to be valued. And folks are not going to sit and just be at a table and be silent. And if you want someone to be silent, then you're not getting what you need.
Yeah, absolutely. So I want to talk about, and we've kind of discussed it a little bit, but just the power of collaboration and partnerships and looking at things from a systemic approach. Can you talk more about innovative partnerships that you're engaged in and why that's worked?
Well, I'll speak to one that I'm intimately involved in. It's like a second job, but it's also a second passion, and that's focused on North Lawndale, but the North Lawndale CCC Community Coordinating Council. And it's a beautiful synergy of volunteers that have come together based on engaging the community, the whole community around what life needs to look like. We have 13 different committees that are really hyper-focused, whether it is on technology, whether it's on health and wellness, whether it's on workforce, economic development, transportation. Who would have thought transportation is a big issue? Because transportation is a barrier. If your bus doesn't go any further than a couple of blocks, or it's not even there, that partnership, that collaboration is very strong. And it's very focused on the voice of the community. We actually were a finalist for the Chicago Prize, which was amazing. We've been able to get resources to open up a workforce campus, which is headed by North London Employment Network. You've got Richard, who started his 1,000 Home Initiative, and you, of course, Sinai, who's opened up Ogden Commons, which is on the lower floor. We have minority-owned businesses there, and then we have clinical services, state-of-the-art. Now we're looking at other opportunities in terms of what's happening with Invest Southwest down on Ogden and also further down. I'm just saying that the same thing goes on in the Pilsenville Village area, through the Brighton Park. And I mean, it's just so much going on.
And none of it happens in a vacuum or alone, right? Like you just named about 5, 6, 7, 8, 9, 10 organizations that are involved in that work. And I mean, I agree with you, like that's what it takes. I'm gonna switch gears a little bit. We talked a little bit about COVID, and we know that the pandemic has had a devastating effect on Black and Brown communities, which experience both the highest rates of getting COVID-19 and of course, dying from it, sadly. What have we learned about, COVID-19? What have we learned about our public health system as a result of this pandemic? And what should we be thinking about doing differently? Because if I hear someone else say going back to normal, I'm going to pull out the few strands of hair that I have, because it's not about going back to normal. It's about building a new normal. But what have we learned from COVID-19 when it comes to our health systems, or more specifically to public health? David, I'll start with you, and then Debra.
Well, you couldn't look at it, I mentioned before, with the number of deaths in this country as being anything but a monumental failure of the public health system, disproportionate. And of course, it's because we don't have one country or one city. We have 2 cities at least, maybe more. And we have a city that's highly resourced and a city that's poorly resourced. We have not invested enough in public health nationally. And we saw that, we had the heat wave in Chicago, and we failed to understand then. We had Katrina, we failed to understand then, and we had COVID, and we failed to understand sort of how the public health solutions didn't really address those in greatest need. And hopefully moving forward, we learned from that. I know there's work going on in the city now. The health department, Healthy Chicago 2025, has made its aim, like West Side United, to reduce the life expectancy gap by addressing not only the health conditions for which there are huge disparities, starting with cardiovascular disease and cancer, number 1 and 2 in every community in Chicago, but also addressing those social conditions. They have the city plan. Many of the hospitals have finished their community health needs assessments, which are aligned with those plans. And the city has created 6 health equity zones covering the whole city and partnered with community-based organizations for the first time to sort of begin to identify those solutions. So at least there's an infrastructure that's been set up, and much of it's been focused on getting COVID vaccine out into the communities, but hopefully will continue to be funded to allow this work to go on moving forward. This is something that didn't exist before. This sort of connection, as was mentioned multiple times, between the voice of the community with the institutions working together in an integrated or federated way around health and health outcomes. But we've got to raise the wealth level in the city simultaneously. Just focusing on health disparities alone and the health focus will not get the solution if we do not raise and begin to eliminate the great wealth gap that exists in the city that's oftentimes divided by race and ethnicity and gender.
Debra, what would you say? Like, what do you feel you learned or that Sinai has learned in light of the pandemic?
Well, when I saw the question, I'm like, when you know better, you do better. We know better. And what's been powerful is that our behavior has been driven by facts, by information, that we have to drill down to the community and make sure, as we did with the racial equity, and now we're working with the violence piece with the city. we have to make sure that at every level, from beginning to end, the community is at the table to help frame, because they're the ones that will experience the result of our not taking advantage or not using those lessons, kind of thing. So I think we have to, be in a state of readiness, not of fear, but of readiness.
Yeah.
Taking those lessons learned and continuing that. And it can't be a political continuing. It has to be something that is in our DNA now.
Yeah.
In terms of how we work together.
That sounds like take the politics out of things, which is so hard because this is Chicago.
It is.
So in our last couple of minutes, like I want us to be aspirational, and I'll start with you, David. Let's describe your vision for a healthy community. What does that look like? What's the thing that we should be shooting for?
Well, we know that the underpinnings of health come down to two things, basically. And if we can make a difference, is educational achievement and economic vitality, and others being able to make a living and have a certain amount of money. We know below median income in the United States that life expectancy begins to drop. And so I think a healthy community is one in which every child has the ability to achieve educational outcomes, and that we're actually paying wages that people can live on. Notice I didn't say anything about health. Certainly there's got to be places to walk, and you've got to have access to the kinds of things. But if there's money and there's education, those other assets will follow. And it's why, my institution, we've been increasingly focused on these structural underpinnings of health, in addition to providing health and healthcare. This will not be solved by putting clinics on every corner, but by giving people the potential to live full lives that they've been deprived of it. And what we have to do is remove the obstacles. We don't have to, people don't need to be enabled. People have the aspirations themselves to achieve, but we put obstacles in their ways, and we just have to remove them. They're educational and they're economic largely. And if we can do that, we can make a big difference.
Debra, I'm going to give you the last word on this. What's the vision? What's your aspiration for communities?
That our communities across the city, that the divide has been erased. And that when we erase the divide, we're looking at a well community, a thriving community, and thriving defined by whatever that means. But it doesn't mean that you're being challenged by what is existing now around health inequities. It means that this is a thriving, and the underpinnings of what creates that thriving life has been addressed.
And we'll leave it right there. So I want to thank the panelists for their participation today. It was a robust conversation, and thanks everyone for watching and your amazing questions. We are very excited about this partnership firsthand segregation event on health equity. We're asking people to visit WTTW.com/firsthand to explore all of the seasons of Firsthand that are looking at gun violence, coronavirus, poverty, and other issues. So thank you all so much for participating. Thanks for a robust conversation. And I think we've got a little bit of a video to close us out.
Thank you.